When we sit down, it's time for the conversation, and I am joined by Dr. Nelly Bosire for our conversation today. Remember, we want to pay homage and celebrate all the COVID-19 heroes and heroines who, when the rest of us are being told to social distance and stay at home where possible, they're always putting themselves at the line of risk to ensure that you're safe and essential services are delivered to you. Before we introduce our guest and have her come on the show, let's just go through her background briefly. And Dr. Nelly Bosire is a consultant obstetrician and gynecologist. She's also a member of the Kenya Medical Association Advocacy Committee. She has an MB-CHB degree from Moi University and a master's in obstetrics and gynecology at the University of Nairobi. She served as the first chair of the Nairobi branch of the Kenya Medical Practitioners and Pharmacists and Dentists Union, KMPDU. She also served at the Kenya Medical Practitioners and Dentists Council as a board member and the chair of the training committee, and she is currently the current chair at the hospital advisory board at the St. Francis Community Hospital. Thank you very much, Dr. Bosire, for making time.
Thank you for having me on the show.
It's a pleasure. Let's just begin by putting some facts into perspective. When the rest of us are being asked to stay at home, like I mentioned at the beginning of the show, doctors are at the forefront of the war against COVID-19. Just to personalize the whole situation, what has been the experience of doctors during this whole COVID-19 pandemic outbreak worldwide?
Well, it's been an interesting experience for all of us, and also important to note that the experience is not universal. There are doctors who are really at the forefront, and for them, the experience is actually very intense. These are the doctors who man our accident and emergency units, and we've also had the doctors who man the actual isolation centers and those who are taking care of patients in the intensive care unit. So medically, we categorize exposure risk based on the kind of contact that you're into the patient, coming into when you're interacting with the patients. And there are those that are low risk, and there are those that would be very high risk, which we call procedures that call aerosolizing procedures where the patient is likely to easily transmit the infection to you. And so for those, particularly our anesthesiologists, are at really great risk, because these are the ones who have to see these patients who are sick and coughing and have to, for instance, intubate them, a very close contact procedure that can very easily transmit infection to these doctors. They've gone through various experiences, and I think in terms of doing the work doctors do, they're trained for it, and so that's not a problem. But of course, there are the personal challenges that come with it, you know. I could be sitting in my clinic and the mother walks in for regular antenatal care, and 3 days down the line, if she calls me and says she's tested positive for COVID, it changes my whole experience. I've gone from just, you know, calmly, very easily, cordially interacting with my patients to having to wear protective gear to keep not just myself, but to also keep our patients safe. It's an experience when you walk into the hospital, and normally in maternity unit, people are not sick, you know, they're just having babies, and it's a lovely experience. And now you have to tell them that, look, I have to keep you safe, and I have to wear all this gear, and you too have to keep me safe. And in as much you are in pain, I still have to have you in a mask. So it's not that easy. We worry about taking infections home to our families. A lot of us will still have to go home and stay in the same households. Some of us are expectant mothers, and you can imagine how worried that these kinds of doctors get. Some are having small babies. We have doctors who are still not. So we do try to reorganize them so that they're in less risk, but it's still the same. However, away from doctors, I think the really at-risk cadre of staff that we don't talk enough about are the nurses. The nurses, honestly, they bear the brunt of everything, because number one, patient walks into a hospital, who is screening this first contact is always the nurse. After the doctor has seen and given orders on what needs to be done on the patient, the nurse is the one who is continuously in contact with the patient, giving the drugs, giving bed baths, doing procedures on them. They are always very high risk. They are an extremely vulnerable population. A lot even get that much support from home where they come from. So you find everyone is intimidated. We have had nurses, for instance, one of the nurses at Kenyatta Hospital who went home and the entire community sort of ostracized him and his family. He was already tested and he was negative. Nobody wanted to hear of it. So it's been quite an experience. And in as much as we talk about not stigmatizing the patients, it's also very important to realize that the caregivers who take care of them are also very much stigmatized because of the kind of exposure they are always coming into contact with.
That comprehensive analysis of what it takes to be at the forefront of the fight against COVID-19. Now, when the disease broke out in the country, the government took some measures, some were economic, some were political, and some were medical interventions to try and contain the spread of coronavirus. What do you take of some of the measures that the government put in place to contain the spread of coronavirus, particularly those that are geared towards the medical front?
Well, at first, we have to understand that when we have an absolutely new medical condition that has been diagnosed, a new infection like COVID-19 is, it doesn't matter how well advanced you are as a country or whatever, there is no country that is ever prepared to deal with this. And I think this has been very obvious, as we have seen in the response across the world. It doesn't matter whether we are in the first world or in the third world. Every country that has gone into trying to put measures in place has experienced a lot of challenges and shortcomings. For our government, we can see the effort. There's a lot that has been done that is very well meant. There's a lot that is planned to be done. I think our biggest challenge has been on the execution, not the decisions that are being made. The decisions to encourage isolation and quarantine as per prescriptions by WHO. This is standard practice across the world. We have seen our government taking measures to do that. And yes, it has done a lot, right? But there's been a lot of the implementation that when it comes to the people implementing, they are not implementing it in the spirit in which they're recommending people had in mind. So that, I think, has been...
Sorry.
Well, we always say that whatever we do in the medical world should always be patient-centered. We know that has to trickle down to beyond now the actual, let's say, person who is sick or the person who is exposed, because we're now dealing with population medicine. And so in terms of the implementation, first of all, we feel like a lot that should be guided by the Ministry of Health has been ceded to the Ministry of Internal Security, which is highly inappropriate, because then we have ended up delegating a very delicate responsibility to people who do not have the capacity to comprehend what it means. So for instance, when we are talking about quarantine, you will see that all the quarantine centers we have actually had in the country have been manned by police personnel. Why is that? Why is that? They're not a danger to us. They're not a threat to the country. They're not terrorists. So already that creates the environment of hostility to these people who are trying to stay away to keep everybody safe. That is a challenge, and that should implemented through the public health department. We should have seen those places manned by nurses in uniform and doctors, and not by security forces. That is an issue. Security forces should have always been a last option. We say public health measures are only effective when the people who are being taken care of own the decision and are willing participants in implementing. We haven't seen that. We have seen the implementation of burial, for instance, stepped on so many toes. It has absolutely not taken into consideration the system, the WHO recommendations, the will of the people, our culture, who we are. It is actually possible to implement the measures, the public health measures, in a friendlier, more acceptable manner than we've actually seen.
You think this is the reason why, even as Kenyans are taking these cautious measures, they're doing it, it's as if they're doing it for the government? For example, you must wear a mask. People are having masks, but they're not wearing them. Some are wearing them under their nose, on their chin. Do you think that's the reason why Kenyans have not been duly sensitized. It's forceful use of authority to just ensure that these things come to pass.
Absolutely. Look at it, for instance, we never made it, okay, we people to wash hands, use sanitizer. We asked them, we explained why it's important. We explained how this kills the virus. And we simply voluntarily washed hands. People have voluntarily used sanitizer. We have seen our matatus where people are boarding buses and they're actually willingly being given sanitizer, and they complied. But why then did we have to make it illegal to not wear a mask and put it in law? It means then we have handed it over to the police, and now it has become a law enforcement issue, which it should never have. It should never have. We should have encouraged people, explained, look, this is how the mask works. This is how it protects you. This is how it protects me. This is how we handle it. And this is why we encourage you to wear them all the time. Because you will see a lot of the population that actually understand what the mask does for them will willingly wear this mask. They even started wearing masks before they were made mandatory in the country. So this is the kind of thing we're talking about, that let's not make it a legal issue. It's still a very much a medical issue. And if we handle it from the medical perspective side, we're...
Okay, so, and also this speaks to mass testing. I remember when Mombasa County Governor Ali Hassan Joho went to the media and spoke very bitterly because Old Town residents, only 10 of them presented themselves for mass testing, and the government was targeting about 1,000 or 2,000 people. People have developed this sort of cold feet to some of these interventions that the government is taking. We understand that far, but I want you, from a doctor's perspective, to speak to people. Why is it important that they should try and comply to keep you guys safe? Because you guys are putting yourself at risk to ensure that those who are sick get better.
We have learned very good lessons from the care we have accorded this country in HIV. And remember, we went through the same hurdles to encourage people to voluntarily turn up for counseling and testing. And what happened? It was more of a carrot and stick kind of thing. We told people that, look, know your status so that if you actually need intervention, we can be able to afford you care early enough to prevent death. And it was very clear. We had access to antiretroviral drugs. We enrolled them in CCC. They got their prophylactic medication for free. They got access to counseling. They got access to support groups. And people realized, this works for me, and I want to be part of this. And we have been able to have larger and larger turnouts, and it has now become mainstream. No one reminds anybody to go and get tested for HIV. Two, HIV will kill you after 10 years if you have good immunity. So I think we have to try and see what lessons we learned and apply them here. But one of the things I think that has really been a major hurdle to why people are refusing to get tested in the first place is the aftermath. So I test positive, and then I am taken to hospital. I have no symptoms. I don't feel sick, but I'm going to be in the hospital for 2 to 3 weeks at my own cost. That has been a huge hurdle that people are not appreciating. And what happened when the government actually said that, look, treatment in public institutions is going to be free, we actually saw some improved compliance in regions like Kawangware. So those are some of the things. Not come for free testing, and thereafter then you make it my problem how I get sorted out. The second issue has been encouraging even home isolation, which wasn't even an option to begin with. We weren't having options of home quarantine. We weren't having options of a home isolation. And remember, quarantine is for the person who is exposed but not positive, and is therefore being kept away to monitor them in the event they turn positive, or after 14 days, if they're negative, they can be released back to the public. Isolation is for those who have already tested positive, and they're being kept away so as not to infect other people. So both isolation and quarantine can actually happen in situations that are not institutionalized. And this is one of the things we need to encourage. We need somebody to willingly come and say, look, you've tested me, I've tested positive. I know I don't have symptoms, but in my house, I live in a single room house and we are 4. So there's no way I can be able to safely isolate myself. I need help from the government to safely isolate me. However, those who have the
Just
capacity
to
to do.
move on swiftly to some of the challenges that you guys face while you are at the front line in the fight against COVID-19, what are some of these systemic challenges that have come through for you guys?
Or the most obvious has actually been a lack of access to the PPE. And PPE, in as much as the government has put a lot of effort in availing it, has been a challenge. It has really been a challenge because when we talk about PPE, first, there are different levels of PPE. So as an institution may have adequate number of masks and adequate number of gloves, but that's just level one. So by the time somebody needs to have the whole level 3 PPE, how many institutions have the entire proper suits? They have the proper N95 masks. How many of them have face shields and all these things? And those have not been availed in adequate numbers. Two has been adequate training, because first of all, this disease is new. We have to understand that. It means that even the guidelines that we have will keep changing as we continue to get more and more information about the disease. This information needs to trickle fast enough to the healthcare workers for them to keep changing our practice in line with what is best practice based on evidence that's coming out. That hasn't been as effective and as rapid, and of course with the limitations that we cannot even have now face-to-face trainings, which sometimes are a lot more effective than online trainings. That has been one of the challenges we're coming through. The other one has been when healthcare workers do not feel that they get accorded the kind of care they deserve when they themselves get sick. So a healthcare worker is being told, you are sick today. If your private insurance is not going to pay for this disease, and so if you need to be admitted, you cannot even be in probably the best that the service has to offer. We had challenges in Kenyatta National Hospital where even the facilities set aside for taking care of the healthcare workers were inadequate because we hadn't planned for so many of healthcare workers at the same time to be exposed, and also for those who are testing positive. So those are systemic challenges. Some of them, there's a lot going on in addressing them. But there are some that we know there's still a lot to be done. For instance, ensuring the quality of PPEs that are actually being given out there. Some are really good quality, but otherwise, some of them do not meet the quality. And we keep saying the requisite organizations need to ensure that they keep enforcing. We're happy to say that KMA has been participating in actually the testing as the end user of some of these products in conjunction with the KMPDU. And we hope that this will keep rolling out so that the health workers can feel safe and they can feel more inclined to want to serve without fear of favor.
Some of the gaps in the healthcare system in the country that coronavirus has exposed.
Wow, I think for any government across the world, this has been a huge testing point for what do we have in place. Even in systems that think that everything works, they have actually discovered maybe not as much as we think. One of the biggest gaps we have had is not just medical, but it's also on a large scale industrial. Like we went out of our way to absolutely never nurture and grow our industries that actually manufacture medical, essential medical things, whether it is drugs, whether it is things like hospital beds, PPEs, and all. This is not rocket science. The over-reliance we had on importation from China and around the world has actually made us absolutely sitting ducks. So when China needs to use them for their own people, we're left hanging. And we're now scrambling to try and do this at home. These are industries we should have nurtured and grown over time. We should be exporting some of these products. So that has been a major, major issue. Of course, the human resource, which we definitely have talked about through the union, through KMA. We have always said that, look, we do not have enough healthcare workers who are working in this government. And the challenge isn't that we don't train them, we do, but we are not employing them in the places where we need them. Up to now, in as much as the government gave a directive for employment of health workers to deal with this pandemic, we have actually not had a single healthcare worker employed except for at the Kenyatta University Teaching and Referral Hospital. And simply that's because the hospital did not have anyone to begin with who can work there. So they were given a budget and were able to recruit at least 50 workers. But beyond there, we haven't seen counties employing, for instance. There's been a huge, game of musical chairs around this. We are still not addressing it, and it's one of our biggest issues. The third issue is research. So we have seen what's happening in our research institution, KEMRI. And that may be happening at that level, but there's also research that's ongoing at universities, research that should be going on at healthcare institutions, our level 6 institutions, our level 5 institutions. They have never been supported. That has never been a priority for this country. And it's really, really glaring right now just how badly off we are.
Why is it important to sufficiently fund the health sector, not just in hospitals, but also research?
We always say that the health sector isn't a sector that is going to give back. It's not a profit-making venture. You have to understand that everything you pump into the health sector is going. Nothing is going to come out. However, the fruit of a well-funded, well-run healthcare system is manifest in the rest of the economy. When you have a healthier population, it over time will reduce what you have to put into the healthcare system, because you stop dealing with sick people because you put measures to ensure wellness to begin with, not just to treat those who are sick. So we then have a healthier population. We then have people who are more productive in what they do. We're talking about a well-funded sector that ensures that even the manufacturing aspect is working, which is still job creation for our very own people, which is utilizing the brain that we train in this country in our universities, creating jobs for our own graduates instead of training them for the rest of the world to benefit from them, because we have refused to create a space to utilize them properly. So it's not in contention that we must fund our health sector. This has been, in all the gaps we have seen, we need to fund it, and not just in the curative, but even in the preventive and in the research aspect, as we have seen. We have seen what KEMRI has done, getting international recognition from WHO, being able to manufacture reagents in our own labs. That tells you the capacity our people have. We need to equip them to use that capacity.
Dr. Busire, as we wind up, what are some of the, let's say, top 3 lessons that we've learned so far from coronavirus, so we continue to learn?
I think lesson number 1 at the very, very top is that home is always best. Our politicians are stuck with us now. COVID is here. They shall be treated at our hospitals. They can no longer have the pleasure of running out of this country. I hope this is a wake-up call for them that we must invest in our own health sector in this country, for the benefit of not just the mwananchi, but